Well, I'm really pleased to have with us today Dr. Jane Philpott. And of course, many people know that Dr. Philpott served as the health minister for Canada. And she and I had the great pleasure to work together when I served in that capacity in British Columbia. But Jane is also an accomplished family physician, an educator, and a global health champion. She also served as Minister of Indigenous Services and President of the Treasury Board, and recently appointed to be Dean of the Faculty of Health Science at Queen's University, and also appointed by the Ontario government as a special advisor on their data platform. So welcome, Jane. It's so nice to see you again and have you talking with us this morning. So I want to start off by, getting your thoughts about why you wanted to take part in today's conference, your experience working in a congregate living center, and just your thoughts about the way the pandemic is affecting seniors across Canada.
Well, thanks very much, Terry. And let me start just by saying thanks for inviting me, and a big congratulations to you in your new capacity as CEO of the BC Care Providers Association. This is fantastic. As you said, you and I worked closely together during the time of some interesting negotiations around funding for things that actually will have impact on our conversation today. But certainly I didn't hesitate on the invitation because I know the tremendous work that your organization is doing in British Columbia. British Columbia has in many ways kind of been a model to the rest of the country in terms of really a strong provincial response in terms of recognizing the vulnerability of older people and making sure that there was a strong, cohesive response to the early outbreaks that took place in the context of the pandemic. In other provinces, I would argue that it's been perhaps, there are scattered stories where things have gone well, like right here in Kingston, Ontario. We're one of the regions of Ontario where we haven't had any outbreaks in long-term care facilities, for example, but other parts of Ontario have not done so well. And as you said, I did have experience myself in the spring working in a care facility, not a long-term care facility. It was actually a group home for adults with severe disabilities. But of course, many of those were people who had lived in the group home for decades and are in fact older people themselves. So this is something, the work that you're doing there, that is incredibly important to me in my capacity, both as with interest in health policy, but also now with my interests in academia and how we train health professionals to think about their responsibility to recognizing the unique needs of older Canadians.
And, talking about the health profession and the human resource challenges that we face in seniors care, it's clear when the Canadian Forces went into care homes in Ontario that one of the biggest concerns was the lack of staff. People fell sick or they were short-staffed to begin with. Can you talk about the challenge that we face in this sector as it relates to attracting, retaining, and paying people to work with seniors?
Absolutely. The issue around the workforce and its impact on the pandemic is one that cannot be sufficiently emphasized or overemphasized. We need to continue to talk about it and making sure that we get that piece right, because whether you're talking about the agri-food sector, and we see how in the agri-food sector the workforce has been impacted by people who work in vulnerable situations, either because of their pay or because of the fact that they're working in close proximity and haven't been provided the right kind of equipment. Those very same issues, as you and I know, are really there in the health workforce, and particularly in settings where people are obliged to work under circumstances where they may or may not have the right protection. So making sure that people are paid well, as you said, is certainly one of the #1 issues. And we have seen that people who are often the lowest paid members of our health teams are the ones who are most vulnerable and also most necessary in their response to the pandemic. But there certainly is a tremendous amount of work that organizations like yourselves can and are doing around recognizing what those standards should be. What is the appropriate standard for the workforce, both in terms of how much they get paid, but also these context in which they're working. And we've learned some pretty hard lessons about that over the last number of months.
And Jane, people look at the health profession as an attractive profession. They might think about a nursing career, but I think for many young Canadians, they find it maybe hard to step into that. I think that training as a healthcare aide and then maybe laddering up to an LPN and perhaps an RN is a way to bring people into the profession. What are your thoughts about ways that we can make this a really attractive place for people to work? I mean, obviously, paying more money is one thing, but is there a path to a fulfilling career for people as an entry level, perhaps as a healthcare or personal services worker, as they're referred to in Ontario?
There's no question that health professions require a big team, and it takes everybody working together. And often people do find themselves working in one particular part of the professional spectrum at a period of time, and then discover that actually they'd like to do something else. So we see, as you said, often people who will work as a personal support worker and later decide that they want to actually do their training in nursing, or we'll see people who start as physiotherapists and then decide that they want to become a doctor. The important thing is, though, is that everyone on the team is valued, that we recognize that these teams absolutely depend on one another. It's not a hierarchy. It's actually it is a team where we look out for one another. We listen to the needs of one another. We acknowledge the incredible contributions that every member makes. I saw that when I worked at this group home in the spring, and recognized the extraordinary role that healthcare aides provide in terms of meeting the day-to-day needs of the residents of that home. And I think Canadians in general have really been awakened to the fact that, doctors get put on a little bit of a hierarchy or a pedestal perhaps, but actually we actually need every single member of the team to be supported, to be respected, to be remunerated appropriately, to make sure that in the end of the day that people's health needs are addressed. And
one curious thing about the pandemic, particularly as it relates to the impact on seniors, is the difference among provinces. We saw in Ontario and Quebec a tremendously hard-hitting impact of COVID-19 on seniors. Not as much in British Columbia, although with the resurgence, we are seeing some outbreaks here. Is there anything that you can think of that would sort of be key factors in why some provinces were more impacted in long-term care than others?
It's a great question, Terry, and I think we can make some hypotheses. I suspect for years to come, people will be dissecting and analyzing what happened and why some places did better than others. And some of these factors are beyond people's control. I mean, the geography of where a virus decides to land and have its first case is often something that the health professionals or the health system itself can't control. There are forces outside of health that have an impact on that. But I think that one of the lessons I saw greatly was that people do pay a tremendous amount of attention to hospitals, because, as you know, those are the big dollars. The biggest part of our health dollars are spent on doctors, hospitals, and drugs. And so that's immediately where people's minds go as the pandemic starts to ramp up. Are the hospitals ready? Have they vacated beds so that they're going to be able to deal with them? Are the ICUs ready? Have we got enough ventilators? Is Emerge ready? So all of this was happening. And meanwhile, in some regions, people weren't thinking, what about long-term care? What about home care? You know, have they had their infection prevention control training? Do they have the pipeline for getting personal protective equipment? And we saw regions who were really caught unprepared, either because their hospital sector was so swamped that all of the energy was going there, or because that's where they expected the challenges to be, when in fact, as you know, health happens in the community, and health happens in our neighborhoods, and older people are being cared for in the community, and they're being cared for in long-term care facilities. And our minds didn't instantly go there. Now, I say that as a generalization. There are great examples of when that didn't happen. Here in Kingston, I have to say we have an extraordinary regional public health unit, strong leadership where they diverted public health professionals out of the school system and immediately put them into long-term care facilities. And thankfully, to date, there haven't been any outbreaks in this particular region. But you know, as I say, we've learned a lot. I hope we're all a lot better prepared for what may be yet to come in the weeks and months ahead.
There's been an argument put forward that you know, the federal government should take a greater role in seniors' care. When you and I were serving together and looking at the funding formula from the federal government, you know, it was quite a divergent approach that you took, because in the past, the federal government just sends dollars to the provinces and they're responsible for healthcare, so they use them as they saw fit. And your government, and under your leadership, decided, no, we wanted to look at home and community care, and these dollars were going to go to that, for that, service. Do you think that the government federally might take a similar approach, build on that, looking at funding of long-term care?
Well, your guess may be as good as mine, Terry, as to what's going to happen in the days to come. But there's no question that all orders of government have been under pressure about what their role is, what their contributions are going to be to strengthening health services for older Canadians. And for sure, the federal government has been under pressure. I would say, perhaps unfortunately, I think the pressure has eased up a little bit now that we're not seeing the same rate of deaths that we were seeing in the spring. And I think it's incumbent upon all of us to say, but the challenge hasn't gone away. Of course, we have these major reviews that are taking place right now to sort of look at that and what is the federal government's role. But I would argue, you know, people like to say, well, it's not the space for the federal government to enter into. And as you and I talked about many times before, well, the space is there if the dollars are there, right? You know, if the federal government's prepared to put dollars into whether it be mental health or home care or long-term care, then you know, there are mechanisms similar to the mechanisms perhaps under the Canada Health Act to say, okay, we're going to put X billion dollars into long-term care, and this is where we'd like to see it go, or these are the principles or standards by which we expect these dollars to be used. And so I will not be surprised, let's put it that way, to see the federal government putting some investment into this area, because it's an area that cannot be ignored.
I think, Jane, one of the sort of saddest parts about the pandemic and its impact on seniors, I mean, obviously the unfortunate number of deaths that have occurred in long-term care, but the isolation of our loved ones to keep them safe, obviously, but limiting visitation by family has had a tremendous impact on physical and mental health of residents. Do you want to talk about that a little bit? And are there ways and means of allowing more visitation in a safe manner?
Well, Terry, I think there have to be. You know, I think you know, there are some very sad stories, and we collectively took very serious precautions to protect older people living in congregate settings. But there are some tragic stories, as you know, of people who have died not of COVID, but essentially of the consequences of isolation. And as we age in particular, the quality of life is absolutely got to be one of our metrics by which we measure whether we're serving our communities properly. And to live an isolated existence and be safe from a virus is not necessarily what people are aiming for. They want to be able to find that balance. They need the support of their families and loved ones. So I'm glad to see that the pendulum is swinging to a certain extent. It's tough, and as you know, people have different opinions about this. But I'm glad to see that families are speaking up, talking about how they want to have their loved ones with them. I think an organization like yours that supports that whole spectrum of care is really important, because we're starting to see families say, well, actually, I'd like to keep my loved one at home for longer, because then I know that they won't have the restrictions that an institution might impose on them, but I can't do it unless I get help. And that's where I think those of us who are in the policy space need to say, we need to help families who want to keep their older loved ones in their bubble, but recognizing that those older loved ones have serious health needs. We all have an obligation, I think, to try to support them in doing that, because you know, there will always have to be some protections and rules around what happens in institutions that will make it a little bit harder for people to have the freedom which we all value so much.
Yeah, and what we hear from operators, of course, is that you know, if we allow more family visitations, then perhaps the people that are working on the front lines won't feel as safe, and you know, may not want to show up to work. So it's a delicate balance
Very
between
delicate.
keeping the people working safe and providing that opportunity for visitation. You know, I think there's a role for all of us to play in training family members how to don and doff personal protective equipment, how to, you know, minimize spread of infection, so that we could sort of train people to go in and visit safely. Do you see that as a role that that organizations like ours should be playing?
Absolutely, Terry. I think that's a fantastic area of focus for an organization like yours. For one thing, it shows respect for family members, right? To say that, you know, of course, you know, people are capable of being able to learn what those personal protective measures look like, what infection prevention and control looks like. And, you know, we've seen people making adaptations on even the definition of who is a visitor, and you know, what does it, and there are certain visitors who we acknowledge are essential workers because they provide a service of caring for their family members. So I think that's a fantastic area of work, and I really congratulate you for stepping up and looking at that area.
Jane, the situation across the country is uncertain at the moment. We see some trends that are positive, but you know, this sort of resurgence that we're seeing now. None of us have a crystal ball, but if you're looking to the winter, what are your fears, and perhaps maybe something optimistic that you see happening as we enter into the cold Canadian winter, particularly for you down east?
You're not going to get cold out there, Terry?
No, it's BC.
You're so lucky. What a beautiful place to live. So I'm ever the optimist, you know, even in these dire times. And so I prefer to think on that side of the ledger. And, you know, there are, I have to say, and we've never seen science work so fast, right? You know, the work that's going on in terms of trying to get safe vaccines and think about how to get them available quickly. So it makes it a little hard to predict, because no one's ever seen this enormous number of trials simultaneously taking place for a single pathogen in history, which all makes me believe that is not outside of the realm of possibility that a year from now there will be a vaccine which will be safe, affordable, and distributed across our population. So that's the kind of the good news story. Vaccines are not a panacea. All of those other things will still have to happen, and it'll take time to get the vaccine widely distributed, but that will allow us to be able to change our prognosis for the pandemic. What's the biggest fear? Well, we should be absolutely laser focused on these vulnerable populations and older Canadians are definitely one of the groups that will remain vulnerable. Some people will have to be in institutional care. So how do we make sure that that those institutions have the support they need, have the workforce they need, that workforce gets the support that's necessary, that all of the standards that you're working on are in place, because otherwise we will see another severe wave, and we know the people that are not going to do well. And they absolutely include older people, and whether they be at home or in long-term care. My worst fear is that we will see another severe wave where, a huge proportion of the deaths occur in older Canadians.
You and I used to worry a lot as we went into the fall and winter about flu season and the impact it would have, not just on the general population, but particularly on seniors. We've seen the federal government and provincial governments step up with the high dose flu vaccine. Is there a possibility that we'll actually see a sort of a silver lining in terms of a much reduced flu season that mitigates the impact on older Canadians this year?
Well, there are certainly many indicators that suggest that is the case. I mean, I wouldn't want to suggest that we should let down our guard, and I'll always encourage people to get vaccinated and realize that we can't make any assumptions. But you're right that the measures we're taking around physical distancing and masking and hand washing are all the things that we should have been doing all along. Not the masking all along, but certainly the physical distancing and hand washing are things that in the past, public health professionals have tried to encourage people to do to minimize the spread of flu. And so there are certainly many experts who are suggesting that we may see less flu and cold viruses circulating this winter, and that would be a very good thing in the midst of other bad circumstances.
One of the sort of greatest challenges and pleasures I had as health minister was working with public health officials, because I always used to love the debates we would get into. Dr. Perry Kendall and I and Dr. Bonnie Henry and I would have these great debates about public health issues. For us, it was primarily the opioid overdose crisis. But was one of the most rewarding parts of my job was working alongside people like that had this evidence base, that were really trying to do the best thing for the most people. Talk about the public health officials in Canada, and maybe give your thoughts about the difference between what's going on in Canada, politicians and public health officials, versus what we see south of the border.
Wow, that's a loaded question, Terry. As soon as you introduce the south of the border part, it just changes the whole question. We have extraordinary public health professionals in Canada, as you said, just absolutely fantastic. And boy, you've got some superheroes there in British Columbia. You and I did know that all along. And they have really continued to set the bar in a fantastic way. So I know that you recognize that, and you're all grateful. But, throughout the country, we have great public health professionals, obviously a tremendous Public Health Agency of Canada. The problem for us in Canada has been, that I think it's safe to say public health has been sort of the poor cousin in the healthcare system, right? It's always been underfunded, no matter what order of government you're looking at. People haven't put their money where their mouth is in terms of recognizing that an ounce of prevention is worth a pound of cure. the budget of the Public Health Agency of Canada when I was health minister was about $600 million a year, which I recognize sounds like a whole lot of money. But when you look at health expenses writ large, that's a very, very small amount of money. And we haven't always had all the right public health infrastructure in place in terms of communication and coordination from the federal government to the provinces and those systems. But again, getting back to your question in the context of how have we done better in Canada than south of the border, it's almost impossible to even make that comparison, because I think what we have done in Canada much better is that people have, for the most part, not tried to politicize this pandemic, and I think that's where we see our southern colleagues really struggling, is that this is a classic example of where politicians need to step back and recognize that this is the domain of professionals, public health professionals. They should have the lead voice to put out the messages, and where that has happened, it has really been effective.
And getting back to sort of impact on seniors, if you had a magic wand, what would you do tomorrow to going forward, reduce the impact on seniors' care in Canada? Because this won't be the last respiratory virus we see, hitting vulnerable populations. So can you give your thoughts on, how we should make systemic and structural changes that would reduce the impact on seniors in the future?
Boy, I want several magic wands, Terry. I don't want just one, because I want to use one wand for getting that vaccine out and circulated across. But you're right that it's the systemic change that we really would need to focus on. And I think that we need to stop with the siloing of health systems and find a way that excellent healthcare for seniors is woven into the rest of the system. That it's, in the case of Ontario, we now have a separate Ministry of Health and another Ministry of Long-Term Care, and then another Ministry of Community and Social Services. When we silo seniors and their care like that, it makes everybody vulnerable. So finding ways that it is acknowledged that people have a right to have access to excellent health care, that's funded, that there are standards that are put in place, like the standards your organization works on, and that people will be held accountable to upholding those standards for care, those standards for workplace safety, etc. I really think that it is that systemic change that's going to require policymakers and providers working hand in hand that will keep older Canadians safer.
And, we obviously, you and I are baby boomers. And so, in 15, 20 years, that wave will really hit, the vulnerable older population. The demographic will be huge. So this is not going to go away. So for politicians, I think they really need to pay attention to the way seniors' care is delivered. And certainly it's been laid bare with the pandemic. Jane, one of the key goals of public health officials and health ministers was to mitigate the impact on the acute care system. We saw what happened in Italy, in New York, and our goal was to really reduce the impact. And here in British Columbia, I can say that they did an excellent job. In fact, to the point where hospitals were nearly empty and, very few surgeries going on. We were celebrating our healthcare heroes, but in fact, when you talk to them, they really weren't very busy. That was not the case in seniors care. The real healthcare heroes, they're all healthcare heroes for sure, but I think the unrecognized healthcare heroes on the front lines were people in seniors care looking after that vulnerable population that was impacted so hard. Can you talk about the role of healthcare aides, of LPNs, of nurses, of administrators, what it must be like to be on the real front lines of this pandemic?
Well, Terry, I think you're absolutely right that those heroes that do that really hard work day after day, we cannot stop recognizing what they do. And you're right, they're not always in the acute care sector, that is for sure. Thankfully, we saw the acute care sector, I think, working more closely with the community sector through the pandemic, and that was kind of the only way to go forward. But I guess I would just again take it back to my experiences this spring in a very severe outbreak that took place in a care facility. It wasn't a long-term care facility, it was a group home for severely disabled adults, many of whom were seniors. And 95% of the residents of that care home were infected. But the biggest challenge was the fact that there weren't enough workers, that for a variety of reasons, workers were forced to leave the facility for their own health needs or because of their own exposure. And it just made it abundantly clear to me that we have not adequately recognized the role, particularly of healthcare aides or personal support workers, because we saw how dependent these residents are and have been for their whole lives on the tender, loving care of aides, various types of nurses, whether they be, as you say, registered practical nurses, registered nurses, nurse practitioners, the whole spectrum. And I would argue that you have to add to that dietitians, the folks who do the laundry, who prepare the meals, who do the cleaning. It takes a village in these kinds of facilities to be able to provide adequate care. And you take one piece of that village away, and the whole place starts to crumble. So I saw that firsthand, and let me tell you, I lift my hands to the team, in particular to the healthcare aides who are absolutely integral. And I saw some real heroes, and they struggled, but they persevered.
I think we've all learned, what the true meaning of essential worker is in the pandemic, and hopefully society recognizes the value that people are providing, and that will mean better compensation, better careers, better futures for those folks. Well, Jane, your new job now, Dean of Health Sciences at Queen's. So, when you look forward, particularly as it relates to seniors care, how do we need to change the system of educating healthcare workers to deal with the wave of the baby boomers coming through the seniors care system? I note that there's something like under 400 geriatricians across Canada. So can you talk about what you think needs to change in terms of health education?
That's a great question, Terry. And yes, I'm absolutely thrilled to have this new role as Dean of the Faculty of Health Sciences here at Queen's University. And I'm really happy that it's a faculty that is interprofessional. So we have a School of Medicine, a School of Nursing, and a School of Rehabilitation Therapy. So everyone works and learns and trains in that interprofessional capacity, which I think is really important. You pointed to one of the big pieces, and that's just, are we actually focusing our training enough on people who want to work with older people? And geriatricians is a classic example where you look at the number of geriatricians we train and the number of pediatricians we train, and it doesn't make sense because we have an aging population, and yet we're training far more pediatricians than geriatricians. So I think that's been acknowledged. It takes a while for the system to flip. Here in Ontario, we are working, for example, on looking at models around medical education where you can potentially even look at who you're going to recruit to medical school based on their interest of what they want to do afterwards, and encouraging the possibility that spaces could be protected for medical students who are interested in a career in geriatrics. I think there's a lot that can be done in that area. We're only beginning those conversations. It has to do with what those funding models are for physicians as well. And geriatricians are amongst the poorest paid of health specialists. And that needs, that obviously needs to change, because while people don't entirely choose their specialty on the basis of remuneration, it speaks to what we value as a society. And I think that there is a tremendous amount of room for improvement.
One of the, sort of goals when I was health minister and we worked together was shifting a little bit more to home care and keeping people in their home as long as possible. And I see neighbors of mine, for instance, where an older resident has some dementia, and her grown adult children are just tremendously supportive. They're there every day caring for at home. Not everyone has those kinds of supports. And there's a big argument to be made for long-term care in terms of socialization and providing that community around people. So do you want to just speak a little bit about that balance, home care versus assisted living or long-term care? And, is there one model that works, or is there a mix of things that has to be tailored to the individual?
I think we will always need a mix. You've spoken very directly to the fact that one family is not the same as the next in terms of what they can provide, and whether it be in terms of the actual home they have, and whether it can be adapted for a family member whose care needs change over time, whether there are people who can take enough time off work to provide the care, including overnight care. Sometimes we see people who have very small families, and it can be really challenging. So there's not going to be a one size fits all for what it looks like to age in this country, and that's why we really need that spectrum. But there's no question that we need to be able to do more to facilitate home care, because you and I know that lots of families would like to keep their family members at home for longer, and maybe we need to break down the rigidity of what it looks like to age in place, and to sort of look at some of these models, which I know you're very familiar with, where people might be able to have more day programs for adults, where we look to communities that are naturally occurring residential areas with a larger percentage of older adults who need to perhaps work together to provide services in the home. And there's a lot of really creative work being done in that area, so that it's not simply an option of full-time long-term care versus not at all, and trying to build that gradient and build the options so that the care that people have will be there for them when they need it.
And folks that are going into long-term care today versus, let's say, 20 years ago, they tend to be older. They tend to have more complex needs. Many have some cognitive decline. I think about 60% of people in long-term care. How does that impact the challenge of dealing with a virus during a pandemic, when you've got people with these complex needs already, particularly cognitive declines? That makes it so much harder, doesn't it, to fight the virus and prevent that spread?
Absolutely, it certainly does, and it has changed over the years, and you and your colleagues there know the high intensity care that is required to really provide a loving, caring, high quality healthcare environment for older adults with cognitive challenges. So I think the virus has absolutely demonstrated that, and that is why these communities were so vulnerable, because if you didn't have the healthcare aides there to be able to provide the basic necessities of daily living, people literally went unfed and went without their briefs being changed and without being bathed. horrible stories that you no doubt saw in the report from the armed forces, for example, of the kinds of things that they saw. And that is, I think, because of exactly what you described, is that the care needs of this population, where people are living longer, but they don't necessarily have the capacity to care for themselves, makes it just that much more complex.
In Australia, they launched, before the pandemic, actually, a royal commission looking at aged care in that country. And I know their system is a little bit different. I understand that the federal government plays a greater role in seniors' care than acute care, for instance. Do we need to have that sort of national review of seniors' care in Canada? Or, there's a potentially a First Minister's conference coming up. Is that something that should be discussed?
Well, I think it's always a good thing if it gets on the minds of the people that both hold the pocketbooks and make the decisions. So I'm delighted to know that that is going to be something that First Ministers will be talking about very soon. And as you know, there have been reviews launched as well, specifically on looking at long-term care and how it should be changed. I think all Canadians have an obligation to keep our leaders accountable to finding those solutions, implementing them. We all need to be prepared to invest. You and I know that doing the right thing doesn't always cost more. It sometimes can cost less if the policies are changed in the right direction to support people getting the care that they need at home, for example. So, but it's going to require us not taking our eye off the ball and recognizing the needs of older people in Canada.
Well, Jane, I know you're very busy starting your new role, and I want to thank you so much for spending time with us today, and for your total dedication, compassion, and lifelong devotion to public health and to looking after a vulnerable population. So, wish you the very best in your future, and hope to talk to you again in the near future.
Thanks very much, Terry, and I wish you the very best in your new role, and congratulations to you and your team on all the work you're doing there.
Thanks so much.
All the best.